கவி ஸ்டார்ட் பண்ணலாமா? Wish you all the best for all of you for your exam. First of all, I'll be covering the important salient features in ophthalmology or salient points in ophthalmology in exam point of view. I will not be able to cover the whole syllabus within this 1 to 1.5 hours. I've shared already my PDF with the organizers of this session of this thing. So you may go through PDF, and you have any things you can get back to me. So I'll be going through the important details. So coming to the conjunctiva, so the questions are simply asked on acute viral conjunctivitis. This is a very simple topic, but you get confused usually in viral conjunctivitis. The vision is not affected. You can have corneal infiltration, particularly in cases of adenoviral conjunctivitis. So nowadays we are seeing more cases of conjunctivitis recently in the last 10 to 15 days, especially in Tamil Nadu. And the adenovirus can cause infiltrate during conjunctivitis. And the mainstay of treatment of viral conjunctivitis is lubricants. This question has been asked repeatedly in various competitive exams. The mainstay of treatment for viral conjunctivitis is not antibiotics, it is lubricants. Then we have acute hemorrhagic conjunctivitis. We have so many questions on acute hemorrhagic conjunctivitis. The question can be a direct question like acute hemorrhagic conjunctivitis is caused by. So the causes are adenovirus, Koncpt virus, echovirus, and enterovirus or picornovirus. So acute hemorrhagic conjunctivitis is caused by. So remember as ACE, adenovirus, Koncpt, echo, and enterovirus. Then you have angular conjunctivitis. So this angular conjunctivitis is caused by Moraxella lacunata or Moraxella axenfeld. So the question is always asked, angular conjunctivitis is caused by Moraxella lacunata or Moraxella axenfeld diplobacillus. Okay, so this is diplobacillus, and the other name of this conjunctivitis is diplobacillary conjunctivitis. Okay, so here the important point we should remember is this type of conjunctivitis is caused by diplobacillary, and the source of infection is the nasal cavity, and this organism will secrete a proteolytic enzyme. So this will act by macerating the epithelium, and the skin shows eczematous changes. So the question is, which of the following types of conjunctivitis is associated with eczematous changes in the surrounding skin? Viral conjunctivitis, bacterial conjunctivitis, diplobacillary conjunctivitis, something like that. So this is a standard question which has been asked repeatedly. Then you have inclusion conjunctivitis. Inclusion conjunctivitis, the most common cause of inclusion conjunctivitis is this one. So this is a chlamydia trachomatis. Chlamydia trachomatis will cause inclusion conjunctivitis. Inclusion conjunctivitis is also called as swimming pool conjunctivitis. I'm not going into the details because I will not be able to cover the whole topics within this 1 to 1.5 hours. I'm just telling the salient things, and the same PDF has been shared with you. You can go through this PDF if you have any doubts. Here, the most common question which they have asked is, see, trachomatis fisto staging will have so many questions. So trachomatis follicles, fisto it goes by F stands for follicles. So trachomatis fisto qualifies for 1, 2, 3, 4 will be the options. So fisto qualifies for 5 or more follicles in the upper tarsal conjunctiva. Then you have inflammation intense, where there is thickening of the upper tarsal conjunctiva, which obscures more than half of the normal tarsal vessels. Then S stands for scarring, where there is scarring in the tarsal conjunctiva, and the scarring in the tarsal conjunctiva is called as dash, Arlt line, ARLT apostrophe S, Arlt line. And then you have trichiasis, where each eyelash will rub the eyeball. One eyelash can rub the eyeball, that's called trichiasis. And you have a corneal opacity, where there's a visible corneal opacity over the pupil. So, fisto staging, you have so many questions. F stands for follicles, I stands for inflammation intense, S stands for scarring, and T stands for trichiasis, and O stands for corneal opacity. The question can be like that itself. Fisto doesn't include one of the following. Okay. So the question was asked, there's always a question on prevention of trachoma. So how do you prevent and what is the treatment given for prevention of trachoma or prophylaxis of trachoma? So in areas with prevalence of more than 10%, what's the prophylaxis fee? You have to give oral azithromycin 20 milligram per kg body weight to be administered for all the members in the society. And tetracycline eye ointment, you have to give 2 times daily for 6 weeks to all children and pregnant women. So the drug of choice for prophylaxis or prevention of trachoma is azithromycin, tetracycline, doxycycline, something like that. So it is oral azithromycin. So then the question can be, the prophylaxis for prevention of trachoma in areas with prevalence between 5 to 10% is given to all the community members or only among family members and close contacts or only patients. So whenever the prevalence is between 5 to 10%, the therapy is recommended only among the family members and close contacts. Where the prevalence is less than 5%, only the patients are to be treated. So these 3 sentences are very important, and then you have several MCQs on these 3 sentences. And then vernal keratoconjunctivitis, I hope all of you will be knowing about that I need not treat, that I need not tell you. So it's a recurrent bilateral conjunctivitis. Which type of hypersensitivity is it? It's a type 1 hypersensitivity reaction. So it's also called as spring catarrh. There's so many questions on spring catarrh. What is the type of ulcer you see in spring catarrh? Shield ulcer. What are the type conjunctival signs you see? You can see papillary reaction. And what are Horner-Trantas spots? This is the accumulation of debris around the limbus. This is called Horner-Trantas spots. So the question can be, Horner-Trantas spots are seen in, it can be spring catarrh or vernal conjunctivitis, Klippchen-Null conjunctivitis, trachoma. So this should not just confuse. Just you have to memorize Horner-Trantas spots are seen in spring catarrh. Okay. So other features which you can see in VKC are, you have a cobblestone appearance and pseudoxanthine. I've already told shield ulcer is seen in VKC. So the treatment of shield ulcer is, so the mainstay of treatment of shield ulcer is the question. So the answer is steroid. Mainstay of treatment for a shield ulcer is steroid. Or the question can be like this. One of the following corneal ulcers can be treated with steroid. Then they can be bacterial corneal ulcer, fungal corneal ulcer, shield ulcer, something like that. So the answer is shield ulcer. So this is by far, this is the only corneal ulcer which can be treated with steroids. All other corneal ulcers, steroids are contraindicated. Okay. So the next question is the mainstay of treatment for vernal keratoconjunctivitis. The mainstay of treatment for vernal keratoconjunctivitis, if the question is asked again, that is topical steroid. This is the mainstay of treatment for vernal keratoconjunctivitis. Then you have other allergic conjunctivitis, which is Klippchen-Null conjunctivitis. So Klippchen-Null conjunctivitis is type 1 hypersensitivity reaction, type 2, type 3, type 4. The question can be that. So what type of hypersensitivity reaction is Klippchen-Null keratoconjunctivitis? That is type 4 hypersensitivity reaction. See, I'm little fast. Please, I'm sorry, because I need to tell you at least salient features. That's why I'm little fast. If you have any things, you can go through this PDF in detail. So then Jane papillary conjunctivitis. So what is Jane papillae? The question is like that. Jane papillae means the papillae which is more than 10 millimeters in size. So this is what is Jane papillae. So the causes of Jane papillae are three. You have a contact lens, you have an ocular processes and protruding corneal suture. Sometimes the question is Jane papillae conjunctivitis not caused by. Then you have a contact lens, processes and protruding corneal suture, and it can be something like VKC or Klippchen-Null keratoconjunctivitis. Then vitamin A deficiency is an important topic. So here you have number of MCQs on vitamin A deficiency. First, you have to know what are the congenital changes in vitamin A deficiency. The congenital changes in vitamin A deficiency are actinic degeneration, complex and hyperplasia, and stromal infiltration. Then you have what are called white-dot spots. So what are white-dot spots? The white-dot spots are because of liquefaction and release of gas by the organism Corynebacterium cirrhosis. So white-dot spots are caused by Corynebacterium diphtheria, Corynebacterium cirrhosis, Neisseria gonorrhoeae, something like that. It's caused by Corynebacterium cirrhosis. White-dot spots are indicative of night blindness. There are several questions on this slide. XN stands for night blindness. X1A is conjunctival cirrhosis. 1B is white-dot spot. 2 is corneal cirrhosis. 3A is corneal ulcer less than 1/3 of the cornea. And 3B is corneal ulcer which is more than 1/3 of the cornea. So you have to know that. Again, this slide is very, very important. You just have to memorize. So how do you give vitamin A dose or vitamin A schedule? All patients who are above 1 year of age, except women of reference age group, you give 2 lakh intonation units orally or 1 lakh intonation units intramuscularly on day 0, day 1, and then 2 weeks later. So remember, all patients who are more than 1 year of age, except women of reproductive age group, you give 2 lakh injection units orally or 1 lakh injection units intramuscularly on day 0, day 1, and 2 weeks. All patients below 1 year of age and children of any age who are less than 8 kilograms, you have to give half the amount. All patients who are less than 1 year of age and children who are less than 8 kg, you give half the. And women of referred to age group, you have to give 10,000 information units of vitamin A orally every day for 2 weeks. If they have corneal thereafter, then you give the adult dose. Okay. Then this is the tricky point. A woman of referred age group, like a woman of 22 years old, is having corneal blindness, which is the following is the recommended dose of vitamin A. Then it is the normal adult dose. If a woman of reproductive age group is not having corneal cirrhosis, then you give 10,000 information units of vitamin A orally for 2 weeks. Okay. Then, so pterygium, there's so many questions that can be asked with pterygium. So the important question is, pathologically, a pterygium is what? It's a fibroelastic degeneration. There are pathologically pterygium is what type of degeneration? Fibrous degeneration, acidic degeneration, elastotic degeneration. So the fibroelastic degeneration. That is one important question that starts with the PHP. And number 2. So what is the difference between the pterygium and a pseudo-pterygium? It's the closest differential diagnosis. In a pseudo-pterygium, you can pass a probe underneath the pseudo-pterygium. That means probe test is positive in pseudo-pterygium, whereas probe cannot be passed underneath a pterygium. That means probe test is negative. Okay. So, and next, the important question on treatment of pterygium, which is asked repeatedly. The most common method of management of a recurrent pterygium is dash. The answer is the tangential autograft. Pterygium excision with tangential autograft. You can have an option of autograft, amniotic membrane graft, mitomethyl or ultraviolet radiation. The answer remains pterygium excision with tangential autograft. Or the best method of treatment of recurrent pterygium, again is an autograft. Or the best method of treatment of a primary pterygium is again autograft. So the answer is autograft. Then the question is, most common cause of visual disturbance in pterygium is astigmatism. It is not pterygium encroaching onto the pupil. Most common cause of visual disturbance in pterygium is induced astigmatism. I'm repeating, it is not pterygium encroaching on the pupil. Most of you will be feeling the pterygium encroaching on the pupil, but not pterygium encroaching on the pupil. It is astigmatism. Then iron deposits close to the head of a pterygium are called dash Stokes line. So these are not direct questions. In ophthalmology, most of the questions are direct. You just have to remember the names and you just have to remember the things. So iron deposits close to the head of a pterygium are called Stokes line. Iron deposits in front of a bleb of a trabeculectomy. Iron deposits in front of a trabeculectomy bleb are called Perry's line. F-P-R-R-Y-S. Perry's line. Iron deposits at the base of the cone in keratoconus is called Fleischer's ring. Fleischer's ring. Iron deposits in sutures around in keratoplasty is called Mann's line. M-A-N-N-S. Mann's line. This can be a question. Iron deposits in front of the head of the pterygium is Stokes line, Mann's line, Perry's line, Fleischer's line. So I repeat, Stokes line is iron deposits in front of the head of the pterygium. Mann's line is iron deposits in front of sutures and keratoplasty. Perry's line is iron deposits in front of the trabeculectomy blood. I hope you understand. Trabeculectomy is a surgery which is done for glaucoma, where the conjunctiva elevates and forms a blood. If you have iron deposits around that blood, that's called Perry's line. And then iron deposits at the base of a cone in keratoconus is called Fleischer's ring. So not much questions on subconjunctival hemorrhage. The most common asked question on subconjunctival hemorrhage is the treatment of a subconjunctival hemorrhage. What is the treatment? It is observation or it is self-limiting. There's no specific treatment for a subconjunctival hemorrhage. These are will be asked as MCQ, so just to confuse you. So you to start thinking, what is the treatment of subconjunctival hemorrhage? No. Treatment of subconjunctival hemorrhage, just wait and watch. So simple observation is the treatment of subconjunctival hemorrhage. Okay. So these questions, these photographs are put because they've been nowadays NEET is having all the photograph-based questions. So I don't think MRB will have this photograph-based questions. If at all you have a photograph-based question, you can just go through net. You will have all the photographs. MRB usually will not have, I think so. So this is a photograph showing an advanced pterygium. So here again, there's a pseudo pterygium. See, there's a difference between this region, the first photograph and the second photograph. The first photograph is growing straight. The second photograph is coming from somewhere else. It's coming from somewhere else down onto the cornea. That itself says it's a pseudopterygium. Okay, next we'll go into the sclera, the most important topic in sclera. What's the most common cause of scleritis? This is a repeated last question. Most common cause of scleritis is rheumatoid arthritis. Most common cause of anterior staphyloma is perforated corneal ulcer. Most common cause of posterior staphyloma is high myopia. I'm telling most common cause of anterior staphyloma is perforated corneal ulcer. Most common cause of posterior staphyloma is high myopia. Question: the sclera is thinnest. So sometimes it can be directly the sclera is thinnest at the intersection of extraocular vein. If you have to be very specific, sclera is thinnest posterior to the intersection of extraocular vein. In NEET, they have asked this question. In AIMS, they have asked so many times. Sclera is thinnest anterior to the intersection of extraocular vein, or posterior to the intersection of extraocular vein, or at the intersection of extraocular vein. Sclera is thinnest posterior to the intersection of extraocular vein. Okay, posterior to the insertion of the extraocular, the sclera is thinnest. Common causes of blue sclera or osteogenesis imperfecta, Ehlers-Danlos syndrome. So all connective tissue disorders where you have joint weakness or hyperflexibility of joint. That means that the collagen defects there. So these cases will have a blue sclera. The common causes of blue sclera are osteogenesis imperfecta and Ehlers-Danlos syndrome. Okay. Then the question is limbal stem cells stem cells in the cornea are present in which part of the cornea? They're present in the limbus. The limbal stem see the key part where the limbal stem cells are present are called crypts. So you have limbal girdle of Vogt. So limbal girdle of Vogt, which is present around the limbus, will contain the limbal stem cells. The question was asked in Gilbert. Stem cells are present in the cornea in which part? Epithelium, limbus, conjunctiva, something like that. The stem cells in the cornea are present in the limbus. What is limbus? Limbus is the question. Limbus is the structure in the angle, is the structure in the cornea, with the conjunctivo-scleral junction, with the conjunctivo-corneal junction, is the junction of the cornea and the sclera. What is limbus? Limbus is the junction of cornea and the sclera. So this slide is very important. So oxygen for the cornea is derived from dash. It is derived from the air through the tear film. So because cornea is an avascular structure, how does it get oxygen then? So oxygen is derived from the corneal epithelium from the air. Glucose supplied from the cornea for the cornea is from aqueous. So oxygen is from the tear film, that means from the atmosphere. Glucose is from the aqueous inside the eye. Thickness of the cornea is more in the periphery than in the center. This question has been asked regarding the thickness of the cornea. Thickness of the cornea is more in the center than in the periphery. Thickness of the cornea is more in the periphery than in the center. Or thickness of the cornea is same both in the periphery as well as in the center. The cornea is thicker in the periphery than in the center. And the cornea is an avascular structure. So I'm not going to the whole PDF which I have given to you. I'm going to the important salient features. So the number of questions again on this slide. Which surface of the cornea is more elliptical? So it's always the anterior surface of the cornea is elliptical. What is the horizontal diameter of the cornea? 11.7. Vertical diameter 11 mm. So horizontal diameter of the cornea is more than the vertical diameter. Questions are always like this. This is a simple question. With regards to the diameter of the cornea, horizontal diameter is more than vertical diameter. Vertical diameter is more than horizontal diameter. Or both of the horizontal and vertical diameter are the same or whatever. So corneal horizontal diameter is more than vertical diameter. The question can sometimes have been asked, what is the horizontal diameter of the cornea? The horizontal diameter of the cornea is 11.7 mm and the vertical diameter of the cornea is 11 mm. What is the refractive index of the cornea? The refractive index of the cornea is 1.37. Refractive power of the cornea is 45 diopters. So what is the total refractive power of the eye? 60 diopters. Total refractive power of the eye is 60 diopters and refractive power of the cornea is 45 diopters. That means it accounts for 2/3 of the dioptric power of the eye. So then, was the drug of choice for fungal corneal ulcer for the filamentous fungi? It's the natamycin. The drug of choice in filamentous fungi is natamycin. Drug of choice in fungal corneal ulcer for the yeast is amphotericin B. These two statements you have to remember. Drug of choice for fungal keratitis caused by filamentous fungi is natamycin. Drug of choice for fungal keratitis caused by yeast is amphotericin B. And we have to know the clinical lesions of fungal keratitis. So clinical lesions of fungal keratitis or important clinical lesions of fungal keratitis are satellite lesions, immune ring of Westray, where antigen antibody complexes meet. And what are the clinical features of hypopene in fungal keratitis? Hypopene in fungal keratitis is convex shape and it is immobile. Immobile hypopyon. It is convex shape and is not sterile. That is infective hypopyon. So this is the question with regards to fungal corneal ulcer, which is the following is true. Hypopene in fungal corneal ulcer is dry. Hypopene fungal corneal ulcer is infected. The hypopene fungal corneal ulcer is immobile. Hypopene fungal corneal ulcer is mobile. It is simple. So hypopene in the fungal corneal ulcer is convex shape, it's immobile, and is infective hypopene. Important clinical features within a fungal corneal ulcer are you have a satellite lesion and you have an immune ring of the state. And then fungal corneal ulcer, the signs are more compared to the resistant child. Whereas a bacterial corneal ulcer, the symptoms are more compared to signs.
Sir, 1 second, sir.
Yes.
Sir, your voice is clear when you're near screen, sir. When you go back, it's not clear, sir.
Okay. I'll try to be closer. Okay.
Thank you.
So then this slide is again having an important question. So whenever they come, the 30 years old farmer who has history of injury with vegetative matter. So these are all will be clues for you to come to the diagnosis. Like predisposing factors for fungal corneal ulcer or injury with vegetative matter. They're agriculture workers. You have immunosuppression and if topical steroids. We'll have a local immunosuppression. So again, these are all the predisposing factors for a fungal corneal ulcer. I've already told symptoms are less than signs and slowly progressive and indolent course. Signs are already told. You have an immune ring of Wesley, you have satellite lesions, you have feathery margins, hypopene which is thick and immobile, and it's not sterile. So this is the clinical picture of a fungal corneal ulcer. See here you have a main ulcer, you have feathery margins with this ulcer, and apart from the main ulcer, you have a separate lesion. This is what is called as a satellite lesion. Can you see? These are satellite lesions. And if you see this hypopyon carefully, so this is not a straight limit. It's slightly convex hypopyon. The fungal corneal ulcer is a slightly convex hypopyon. Then you know for a fungal corneal ulcer what mount you have to do. It's a 10% KOH mount. What does KOH do to the fungi? It dissolves all the contents of the fungal cell wall so that only the chitin of the fungal cell wall will stand in prominence. So KOH dissolves all components of the fungal cell wall except chitin. That is why 10% KOH mount is used for identification of fungus. Then the culture medium used for fungus is Sabro's dextrosagar. Sabro's dextrosagar is the culture medium used for fungus. Treatment, I've already told, the drug of choice for filamentous fungi is natamycin, and the drug of choice for yeast is amphotericin B. Steroids are contraindicated in the case of fungal corneal ulcer, or steroids are contraindicated in the case of bacterial corneal ulcer also. Then there's all the classification which you have to go through. These are the classification of antifungals. Then I want to tell you about this keratoplasty, where you have few questions on types of keratoplasty. See, but suppose if you are doing a keratoplasty, I'm speaking about a full thickness penetrating keratoplasty. So if you're doing a keratoplasty to improve the vision of a patient, that is called as an optical keratoplasty. I repeat, whenever a keratoplasty is done to improve the vision of a patient, it's called optical keratoplasty because it is done for optical purposes. When you do a keratoplasty for a corneal ulcer which is not healed for 6 weeks, when you do a keratoplasty for a corneal ulcer which is not healed for more than 6 weeks with medical management, that keratoplasty is called therapeutic keratoplasty. As the name indicates, you're doing it as a treatment purpose. You're not doing it as to improve the vision of a patient. So whenever you do a keratoplasty for a corneal ulcer which is not healed or which is not responded to medical therapy for more than 6 weeks, it's called therapeutic keratoplasty. Then when you do keratoplasty, in the case of perforated corneal ulcer, that means the corneal ulcer has given way. Now the eyeball has become soft. Now you're doing a keratoplasty to maintain the integrity of the eye. That is called tectonic keratoplasty. So these are MCQs which are asked. Keratoplasty done to maintain the integrity of the eye is therapeutic keratoplasty, tectonic keratoplasty, optical keratoplasty, something like that. So an optical keratoplasty is a keratoplasty that is done to improve the visual acuity of a patient. A therapeutic keratoplasty is a keratoplasty that is done when in case of corneal ulcer have not responded to treatment for more than 6 weeks. A tectonic keratoplasty is done to maintain the integrity of the eyeball. That means it is done in case of a perforated corneal ulcer. Okay. So then you got causes of decreased corneal sensation. The slide is important. The common cause of decreased corneal sensation is the herpes, diabetes mellitus, leprosy, contact lens usage for prolonged periods, and prolonged anesthetic usage. So corneal sensations are decreased in, or corneal sensations are not decreased in one of the following. That is the question. Then herpetic keratitis. See here, I just want to give you basic understanding of herpetic keratitis. I will tell you the epithelial lesions of herpetic keratitis are infective in origin. That means there's an active viral replication. Then only an epithelial keratitis can happen in herpes virus. Whereas stromal lesions and endothelial lesions in herpetic keratitis or in herpes disease or of immunological origin. I hope it's clear. Epithelial lesions in herpes or infective in origin. That means they're active viral infections. Whereas stromal lesions and endothelial lesions in herpetic eye disease or immunological in origin. If we have this concept in mind, we can answer a number of questions on herpes. So, what are the epithelial lesions you see in herpes? Epithelial lesions you see in herpes are dendritic ulcer and geographic ulcer. Now, because epithelial lesions are infective lesions, so what's the treatment for dendritic ulcer or geographic ulcer? Topical acyclovir I want, because you want the virus to stop multiplying. So, epithelial lesions of herpes are infective in origin. That is why infective epithelial lesions are to be treated with topical antiviral drugs. Whereas stromal lesions are immunological in origin. That means you have a disciform keratitis because of herpes virus. It is an antigen antibody reaction. So there, your antivirus will not have any role. You have to suppress the immune mechanism of the host to treat this keratitis. So immunological suppression is done by topical steroid. Now you understand epithelial lesions are infective in origin, so you treat them with topical antiviral. Whereas stromal and endothelial lesions are immunological in origin, so you treat them with topical steroids. So the question will be, falciform keratitis of herpes can be treated with oral acyclovir, topical acyclovir, topical steroid, something like that. So once you know that the stromal lesion, it is always a steroid. Or once you know it's an endothelial lesion, the treatment of choice is steroid. So you don't treat them with topical antivirals. That is why your stromal and endothelial lesions are seen in recurrent herpes, because recurrent herpes is an immunological mechanism. So that is why you don't see stromal lesions and endothelial lesions in primary herpes, because in a primary herpes, the immunological mechanism or the immune system of the body has not been exposed to herpes till now. Once in a case of recurrent herpes, there's already the immune system is exposed to the herpetic virus. Now there's a severe antigen antibody response. I repeat, epithelial lesions in herpes are infective in origin, whereas stromal lesions and endothelial lesions in herpes are immunological in origin. Okay. So based on this, you can write all these things. I'm not going to the details of herpes virus, HSV keratitis. I just wanted to tell you the important things. You can go through this yourself. What are the primary herpes? What is secondary herpes? So what is the most common manifestation of primary herpes in the eye? Most common manifestation of primary herpes in the eye is herpetic conjunctivitis. It is not herpetic keratitis. That's why I asked the question. Most common manifestation of primary, remember, I'm asking primary herpes. Most common manifestation of primary herpes in the eye is herpetic conjunctivitis. It is not keratitis. Okay, I'm speaking about primary herpes. See, there's an acute follicular conjunctivitis, which is the most common manifestation of primary herpes inside the eye. Then in recurrent herpes only, you have stromal keratitis, endothelitis, trabeculitis, uveitis. All these are immunological. Okay, so stromal keratitis is an immune stromal keratitis. It's called interstitial keratitis, or you can have disciform keratitis. Then this can be a photograph-based question. It may be useful for your NEET or next, whatever it is. So you can see there's a central this thing with branch-like trees. So this is the fluorescent staining of a dendritic corneal ulcer because it resembles the branches of a tree. See, here you have a classical thing. So you got tree like branches of a tree. So this is a dendritic corneal ulcer. I'm going through the slides where you feel it's difficult and I want you to have a clear concept. Rest of slides, you can read what is the treatment of dendritic keratitis, it's affected with the treatment. Okay, like that. Then again, the questions we can ask in acanthamoeba keratitis. So acanthamoeba keratitis, one of the following corneal ulcers is associated with radial keratoneuritis. So this is an important thing. Radial keratoneuritis is seen in which corneal ulcer that is seen in acanthamoeba keratitis. Okay, what is the treatment of choice for acanthamoeba keratitis? You have diamidins and bigavenides. These are the treatment of choice for acanthamoeba keratitis. The drug of choice for acanthamoeba keratitis is the question. It can be diamidines or bigavenides. One of the following will be there in the answers. Then, so this is the question. Solomon patch appearance is seen in interstitial keratitis. Okay, Solomon patch appearance is seen in interstitial keratitis. Then keratoconus. Here you have to know important signs in keratoconus. What is Munson sign? Munson sign is prominent angulation of the lower lid because of the protrusion of the cone in keratoconus. It's called Munson sign. You have a thin cornea at the center and then you have a distorted corneal reflex in keratoconus. Yes. So this slide is again very, very important. I've already told you what is Fleischer's ring. Fleischer's ring is iron deposit to the base of the cone in keratoconus. On retinoscopy in keratoconus, what can you see? You can see a scissors reflex. On distant ophthalmoscopy in keratoconus, you see what is called oil droplet reflex. And what is form prostate keratoconus? Sorry, it's the subclinical form of keratoconus. That means clinically it is not still manifested, and it's only a subclinical form of keratoconus. And which of the following is the cause of sudden onset diminution of vision in keratoconus? Acute eye drops. See, in keratoconus, the characteristic of diminution of vision is gradual onset, insidious onset, painless, and progressive. But a keratoconus patient can have a sudden onset diminution of vision because of acute eye drops. So that is the question, which is the following will cause sudden onset diminution of vision in the case of keratoconus. Please go through all these slides when you have time. You have time, you can go through all these, whatever I have given you material. Then this is an important question. Which of the following is the least common corneal dystrophy? Macular dystrophy. Macular dystrophy is the least common corneal dystrophy. Okay. Most common corneal dystrophy is lattice dystrophy. Most common corneal dystrophy is lattice dystrophy. Macular dystrophy is the least common corneal dystrophy. Corneal transplantation is a question. In corneal transplantation, I'm telling again, you don't need blood grouping. You don't need blood grouping and typing or matching. You don't need HLA cross matching. Okay. So the question can be, which is the following is a true statement regarding corneal donation, or which is the following is a false statement regarding corneal donation. Corneal donation, unlike liver transplant and renal transplant, will not need blood grouping and matching, or it will not need HLA typing or HLA matching. You don't need those things in corneal transplantation. That is why I wrote all those. Okay. Next, we'll go to glaucoma. So, cover salient features in cases of cornea and conjunctiva. Now, when you go to glaucoma, the cells which are affected in glaucomatous optic neuropathy, or here always is a confusion whether it's a bipolar cell or whatever it is. It's the retinal ganglion cell. It's the retinal ganglion cell which gets affected in glaucomatous optic neuropathy. In glaucoma, whenever I start a chapter, whenever I start discussion on glaucoma, they'll always tell. So please don't get confused. Glaucoma is a chronic progressive optic neuropathy. I'm telling the definition so that you get a clear concept of this. Characterized by you have an optic nerve head change and corresponding visual field defect according to that optic nerve head change, for which increased intraocular pressure is an important risk factor. I repeat again, glaucoma is a chronic progressive optic neuropathy characterized by optic nerve head changes and visual field defects, for which increased intraocular pressure is an important risk factor. I hope you can understand now. It is glaucoma is not equal to an increased intraocular pressure. Increased intraocular pressure is only an important risk factor for glaucoma. You can have glaucoma even without increased intraocular pressure, which is called normal tension glaucoma. Or you can have raised intraocular pressure, but no changes of glaucoma. That's called as ocular hypertension. So for a patient to be labeled as glaucoma, you should have optic nerve head changes and visual field defects. Suppose there is no increased intraocular pressure, but there are optic nerve head changes and visual field defects. That's called as normal tension glaucoma. You have only increased intraocular pressure, but no optic nerve head changes, no visual field defects. That's called as ocular hypertension. At an undergraduate level, always you will think that glaucoma means there is raised intraocular pressure. No, glaucoma is not raised intraocular pressure. Raised intraocular pressure is only an important risk factor for glaucoma. Based on that, you can you can answer so many questions I'm telling you. So which is the tonometer is used as self-tonometer. That means the patient can check his own IOP. The rebound tonometer. This is the MCQ which is asked. Which of the following is used as a self-tonometer. Self-tonometer is a rebound tonometer. That's in a question. Again, the question is tonometer which is used in tonometer which is used in irregular corneas. When the corneal surface is irregular, is McClellan tonometer or McEmark tonometer. McEmark. Goldman's applanation tonometer cannot be used in irregular corneas. The tonometer used in irregular corneas is McEmark tonometer. Gold standard tonometer is Goldman applanation tonometer. Gold for gold. Gold standard tonometer is Goldman applanation tonometer. Tonometer used in irregular corneas is McEmark tonometer. McEmark. Goldman tonometer is the type of applanation tonometer. That is the question. Shear's tonometer is the type of indentation tonometer. See here I've given, that's why I made the slide. Indentation tonometers is Shear and rebound tonometer. There is your applanation tonometers, Goldman, McEmark, and McClellan. So these are the different tonometers. This slide itself, there are 3 to 4 MCQs. Normal IOP is 10 to 21 millimeters of mercury. That was an MCQ once in JIPMER. Normal IOP is 6 to 10. Normal IOP is 10 to 21. So normal IOP is 10 to 21 millimeters of mercury. Yes, then we'll go to about ophthalmos. By far, all of you know what is ophthalmos. Ophthalmos is congenital glaucoma. The manifestation of eye in congenital glaucoma is termed as ophthalmos. Here you have large cornea, that megalocornea. You have an anterior chamber which is deep. And what a half stria there? These are tears or breaks in the desmal membrane in ophthalmic eye. Tears or breaks in the desmal membrane in ophthalmos is called half stria, and the intraocular pressure is high. Okay. Here, I will tell you one important MCQ. Suppose you have a birth trauma and then you have tears or breaks in the desmal membrane. Then how do you differentiate those tears from the tears in ophthalmos? So half stria or horizontal, H for H. Half stria or horizontal tears in desmal membrane, where a birth trauma tears are vertical or oblique. You put a forceps like that and you bring it out. You put a forceps like that and bring the child outside. You have vertical breaks. Whereas because of the increased intraocular pressure, there are breaks which are horizontal breaks. So you can remember H for H. Horizontal breaks or half stria. Vertical breaks or because of the birth trauma. The question is half stria seen in congenital glaucoma, primary open angle glaucoma, angle closure glaucoma, something like that. So half stria seen in congenital glaucoma. So that one of the following is the classical triad of congenital glaucoma. So you have this is again important MCQ. Classical triad of congenital glaucoma is lacrimation, photophobia, and blepharospasm. You have a classical triad in congenital glaucoma that is lacrimation, photophobia, and blepharospasm. See, I've written half stria concentric to the limbus. And the important question again is, see, treatment of congenital glaucoma is primarily. So one of the following is a modality of treatment of congenital glaucoma. That's always the question. So there's no medical management meant for congenital glaucoma. Congenital glaucoma is always managed surgically. Medical management is only for you to buy time for surgery. So the modality of or the option of treatment or the best option of treatment for congenital glaucoma is medical management, laser therapy, surgical management, or whatever it is. So the best method or the absolute modality of treatment of congenital glaucoma is surgery. That's all. See, treatment of congenital glaucoma, you have this slide is important. So the two procedures which you do for congenital glaucoma are goniotomy and trabeculotomy. Here, you remember goniotomy, if you have to do, you need a clear cornea. Whereas for trabeculotomy, you do not have a clear cornea. So this is an MCQ. One of the following procedure in congenital glaucoma needs a clear cornea: goniotomy, trabeculotomy, trabeculectomy, or. So for you to do a goniotomy, you need a clear cornea. For you to do a trabeculectomy, you don't need a clear cornea. So these are the two modalities of treatment for congenital glaucoma: that is goniotomy and that is trabeculotomy. Okay. Then I'm not going to the details of this. Yes. Here, this slide, I want you to be very crystal clear. I want you to have a concept on this. So see, there is a new, previously we were classifying angle closure into angle subacute or intermittent angle closure, then you have an acute angle closure, then you have a chronic angle closure glaucoma, then you have an absolute stage. Now, the new classification system is primary angle closure suspect. Then you have primary angle closure. Then you have primary angle closure glaucoma. And then you have chronic angle closure glaucoma. So this is the newer classification. Okay. So now going to the details of each classification. See, primary angle closure suspect. That means here you are suspecting that this patient is at risk for angle closure. Okay. This patient is at risk for angle closure. You're suspecting. That means this patient has got an occludable angle. What is an occludable angle? This is the question. An occludable angle is an angle where the posterior part of the trabecular meshwork is not visible for more than 180 degrees. Remember, without indentation or manipulation. You look at gonio lens and you see the angle, you don't indent, you don't manipulate the lens. You don't indent the lens, you don't manipulate the lens. You put lens and you see, then you're not able to see the posterior trabecular meshwork for 180 degrees. That means in 2 quadrants, that's an occludable angle. This definition has not so many MCQs. I'm telling you again, there can be without indentation or with indentation, with manipulation. That can be an MCQ. It can be 2 quadrants, 3 quadrants, 180 degrees, 360 degrees, that's an MCQ. That's why I want to repeat again. An occludable angle is an angle in which the posterior part of the trabecular meshwork is not seen for 180 degrees without indentation or manipulation. If a patient has got this occludable angle, he is called primary angle closure suspect. You know that we are suspecting the disease in him, but he doesn't have any clinical features of that disease. So his intraocular pressure is normal, his optic disc is normal, and his visual fields are normal. So primary angle closure suspect means, so the question can be, what are the following is not a clinical feature of primary angle closure suspect? It can be occludable angle, normal IOP, optic disc changes for the glaucoma, and visual field normal. So definitely optic disc changes are not for the glaucoma. The primary angle closure suspect will have an occludable angle, even have normal intraocular pressure, even normal optic disc, and even normal visual field. Everything is normal except the occludable angle. That's why you put it as an angle closure suspect. When you go to primary angle closure, see, here there is an occludable angle. This angle is closed, and so this angle is closed, the IOP is elevated, the intraocular pressure is increased now because the angle is closed. And then you have a peripheral angle angle because the angle is closed. Once the intraocular pressure is increased, you can have you can or you may not have optic disc changes or visual field defects. If you have optic disc changes and visual field defects, that will go into glaucoma. If they're not there, but only the angle is closed and the intraocular pressure is elevated, that's called primary angle closure. We are not calling it as glaucoma, remember? We're calling it as primary angle closure. That means there's an occludable angle. There is formation of peripheral anterior sinus, because of which intraocular pressure is elevated, but the visual fields are normal, the optic disc is normal. So say this is a primary angle closure. Then we will go to primary angle closure glaucoma, where you have primary angle closure futures plus optic disc changes and visual field defects. So in a patient to be labeled as glaucoma, you should now have optic nerve changes and visual field defects. Is it clear? So if you are labeling a patient as having glaucoma, you should have glaucomatous optic disc changes and the corresponding visual field defects. So I repeat, a primary angle closure suspect is a person who is having only an occludable angle. His intraocular pressure is normal, his optic disc is normal, and visual fields are normal. A case of primary angle closure will have an occludable angle with an increased intraocular pressure, but the optic disc is normal and visual fields are normal. There is a case of primary angle closure glaucoma will have an increased intraocular pressure, you have an optic disc change, and you have a corresponding visual field difference. So if you remember this basic point, that for a patient to be labeled as glaucoma, you should have an optic nerve change and visual field defect. The other things become easy. I'm a little fast, but I cannot help for that. I hope you understand. So this is always a fancy question. Treatment of choice for fellow in acute congestive glaucoma is. MBBS laser eye return. So the treatment was choice for fellow eye in acute district glaucoma. Earliest field defect in primary open-angle glaucoma is paracentral scotoma. Then see this slide again is a little confusing topic. This is lens-induced glaucomas. I'll just make it clear for you. So whenever there is a lens, there's a natural lens. A lens which swells up suddenly. So this is iris. You have an iris like this. Then there's a pupil, and you have a lens beneath. This is a normal lens like this. So they just swells up suddenly. What happens? It pushes the iris forward. When the sun suddenly pushes the iris forward, once the iris is pushed forward suddenly, it blocks the angle. So there's an angle closure. So there's an angle closure. This is happening because of the change in the morphology of the lens. It's called as phakomorphic glaucoma. See here? So the phakomorphic glaucoma, you have an intumescent lens, you have the pupillary block, you have iris Bombay formation. This results in angle closure. So now you understand? There's a change in the morphology of the lens. That means the lens will become intumescent. There's form pushing of the iris, resulting in the formation of iris Bombay, and then there's closure of angle. This is filled with an angle closure glaucoma. So if you do a phakomorphic glaucoma, there's an angle closure glaucoma. The question is like this. A 35 years old diabetic comes with sudden on the pain, redness, and diminished nutrition. On examination, there's an intuitive cataract with a shallow anterior chamber, the intraocular pressure is raised. Which of the following is the most likely glaucoma in him? There are phakomorphic glaucoma, phacolytic glaucoma, phacotoxic glaucoma, something like that. You see an intumescent cataract, you see a shallow anterior chamber, you see an angle closure, that is phacomorphic glaucoma. Okay. Then you have the second term, which is called a phacolytic glaucoma. Here, what happens is you have a hypermature cataract. The cataract has reached the stage of hypermaturity. When you have an hypermature cataract, in the lens capsule, there are microscopic defects inside the lens capsule. And be careful, be attentive and study. The capsule is not breached. There's no major defect. There are microscopic defects in the lens capsule, which you will not be able to see clinically. So through these microscopic defects in the lens capsule, the lens proteins will slowly leak out into the anterior chamber. These lens proteins, once they come out, there's a foreign protein. So these are engulfed by macrophages there in the anterior chamber, and they go and block the trabecular meshwork. Here, remember, the angle is open. The trabecular meshwork in the angle is blocked by the lens proteins. So this is an open angle glaucoma, which has happened because of the lysis of the lens substance. It's called phacolytic glaucoma. I hope you understand. So there's a hypermetric cataract where there are microscopic defects in the lens capsule. Now the lens proteins with this microscopic defects will enter into the aqueous. In the aqueous, the macrophages will engulf this lens protein, and these macrophages will go and block the meshwork. So that is why there's raised intraocular pressure. But the angle is open. So this is happening because of the lysis of the lenticular substance that is called the phacolytic glaucoma. Phacolytic glaucoma is also called as lens protein glaucoma. Okay. Then we come to the third situation where there is a sudden injury to the lens. So there's a penetrating injury, capsule of the lens breaches out. Now here the lens protein will not come out. Particle of the lens only will come from directly. And they will go and block the trabecular meshwork directly, not the macrophages. And there is the rise in intraocular pressure. That's why that's called as a lens particle glaucoma. You understand? So the basic difference between lens particle glaucoma and lens protein glaucoma is the integrity of the capsule. In a lens particle glaucoma, capsule is torn, so the lens particle will go directly. Whereas in lens protein glaucoma, capsule is intact, so only lens protein will leak out. And then you have a phacotoxic glaucoma, which is same as lens particle glaucoma, but the intraocular pressure rises after a certain time because there is a sensitization to lens proteins which has to happen. There's a toxic reaction which has to happen, so it will take time, and that's why it's called the phacotoxic glaucoma. I repeat, so glaucoma, this is occurring because of a swollen lens that is changing the morphology of lens. It's called phacomorphic glaucoma, and it's an angle closure type of disease. and it's the angle profile. Then, in a hypermature cataract, where the capsule is intact, the lens proteins are leaking out of the capsule, the angles from macrophages, they go and block the trabecular measure, and then there is an increase in intraocular pressure, that is phacolytic glaucoma. But in any cataract, where the capsule is breached, the lens particle itself will come out directly, and then they block the trabecular measure, therefore lens particle glaucoma. Whereas, if there is a latent period between the event and rise in intraocular pressure, because of the sensitization lens protein, it's called phacotoxic glaucoma. On this slide, there are numerous questions. If you understand the topic, you can easily answer any question. Hope I made you understand. Then this is another important thing, the slide, glaucomatous crisis, also called as Forstner-Schwarzman syndrome. So many times they will ask questions. It's a fancy topic for the examiners. Recurrent character range in front of question. The fine kinetic precipitate. There's no posterior communication. Dilated pupil, the eye is white. When you have uveitis, usually the eye is red. But in Forstner-Schwarzman syndrome, the eye is white. It affects young adults. So they will ask you, the question is like, an young adult comes with a white eye, non-examination, his intraocular pressure is high, he gives recurrent attack of the same episode, and what is this? This is glaucomatous crisis or Forstner-Schwarzman syndrome. Treatment is with topical steroids and anti-glaucoma medication. Please go through this slide. This slide is very, very important. Systemic anti-glaucoma medication. There are only two systemic anti-glaucoma medications. One is acetozolamide, which is given orally, and the other one is mannitol, which is given intravenous. Anti-glaucoma drug which is unsafe in children. These are all direct questions. Anti-glaucoma drug which is unsafe in children as primary. Anti-glaucoma drug causing drowsiness was primary. Anti-glaucoma drug causing heterochromia is prostaglandin. It can be latinoprost or biotropos or whatever. Anti-glaucoma drug causing black deposits in the conjunctiva, which is epinephrine. Anti-glaucoma drug which is contraindicated in uveitis is prostaglandin again. I made this slide for so many questions, so many question papers I've got, and then I made this slide. So anti-glaucoma drug is contraindicated. Anti-glaucoma drug is called high risk deposits. Anti-glaucoma is contraindicated in uveitis, like that. So this slide is very, very important. Please memorize this slide. Then we go to lens. So what type of subluxation occurs in Marfan syndrome? You have a supraotemporal subluxation. What type of subluxation in homocystinuria? You have an inferonasal subluxation. Wheel Marchesini syndrome, you have what is called microspherophakia. That means the lens will become spherical. Instead of being convex, it becomes spherical. So microspherophakia is seen in Wheel Marchesini syndrome. But the most common type of congenital cataract, blue dot cataract. Most common type of visually significant congenital cataract is zonular cataract. Remember, most common type of congenital cataract is blue dot. Most common type of visually significant congenital cataract is zonular cataract or lamellar cataract. Whatever zonular is also called as lamellar cataract. Fluctuating refractive errors. If a question is been asked, fluctuating refractive errors are seen in adult population, normal, like the fluctuating refractive errors are seen in diabetic cataract. Diabetic cataract is also called as snowflake cataract. Onion peel appearance is seen in posterior polar cataract. Type of cataract where you see onion peel appearance. With a question with the posterior polar cataract. Complicated cataract. What are the types of appearance you see in complicated cataract? Breadcrumb appearance, polychromatic cluster. These two words you remember. Breadcrumb appearance and polychromatic cluster are seen in this type of cataract. Complicated cataract. See, posterior subcapsular, breadcrumb appearance, polychromatic cluster. The other concept, the other name for complicated cataract is rainbow cataract because you have polychromatic cluster. Here, on type of cataract surgeries, you will always have a confusion. Small incision cataract surgery is not small incision. That is what I wanted to tell you. So there are three types of cataract surgery: conventional extracapsular cataract surgery, small incision cataract surgery, and phacoemulsification. In a conventional extracapsular cataract surgery, incision is large. You have 8.5 to 9 mm incision. Whereas in a small incision cataract surgery, the incision is around 6 millimeters. 6 millimeters. S size DS. Small incision cataract surgery, the name is a misnomer. The incision size is 6 millimeters. Whereas in for multiplication, the incision size is 2.8 millimeters. So which of the following will have the least incision size in cataract surgery? The answer should be for multiplication. It is not small incision cataract surgery. Small incision cataract surgery, small incision cataract surgery will not have smallest incision. Phacoid multiplication is the type of cataract surgery with the smallest incision. Small incision cataract surgery has size of 6 to 7 millimeters. Okay. This is again intracapsular cataract extraction. You can remove the whole of the lens along with the capsule. In extracapsular cataract extraction, nucleus and cortex are removed. You leave the capsular bag intact. That's the difference between ICT and ECT. What type of energy is used in phacoemulsification? Phacoemulsification uses ultrasound energy. The type of energy which is used in phacoemulsification is ultrasound energy. That's what they will have. Type of energy used in phacoemulsification is ultrasound energy. That's a question which have been asked repeatedly so many times. Material used for making non-foldable intraocular lenses are polymethylene with acrylate. Which type of laser is being used in cataract surgery nowadays? Femtosecond laser. This is an important question. Most common late complication of cataract surgery is posterior capsular opacification. Most common late complication of cataract surgery is posterior capsular opacification. This again is a table which is very important. Always one of the following is an advantage of direct ophthalmoscope. One of the following is an advantage of indirect ophthalmoscope. That's always there. So you need a condensing lens. That means apart from the ophthalmoscope which are using, you need another lens in indirect ophthalmoscopy. That means that's a disadvantage. In an indirect ophthalmoscope, the image is real and inverted. Whereas in a direct ophthalmoscope, it's virtual and direct. But you get more magnification in direct ophthalmoscope, 15 times magnification. And stereopsis. The indirect ophthalmoscope is a binocular thing. That's why you have stereopsis. Whereas direct ophthalmoscope is a uniocular thing. That's why you don't have stereopsis. Okay? So this table you have to remember. This table you please go through. Then what is siderosis bulbi? Siderosis bulbi is iron foreign body. Manifestations of an iron foreign body in the eye is siderosis bulbi. Manifestations of copper foreign body in the eye is called chalcosis. So which of the following is an dangerous intraocular foreign body? The question is like that. If the answer has pure copper, mark as pure copper. If the answer doesn't have pure copper, it has iron and copper as the option. You have to go for iron. I'm telling which of the following is the most dangerous intraocular foreign body. If among the four options, if you have pure copper, you mark as pure copper. If you don't have pure copper as the option, you have copper, iron, nickel, something as the option, you have to mark iron as the option. Okay. Which is the earliest feature of diabetic retinopathy? Earliest feature of diabetic retinopathy is microaneurysms. Where do microaneurysms are what? They're outpourings of the capillary end of the venule. They're outpourings seen at the capillary end of the venule. The earliest manifestation of diabetic retinopathy is microaneurysm. Okay. So next you have to know 4-to-1 rule. 4-to-1 rule in severe NPDR. 4 quadrants having hemorrhages and microaneurysms, 2 quadrants with venous bleeding, and 1 quadrant with irma. If you have any one of the following, it's severe NPDR. If you have 2 of the following, it's very severe NPDR. That is what 4-to-1 rule in severe NPDR is 4 quadrants having this, 2 quadrants having this, 1 quadrant having that. That can be just around. That can be just a question like that. Okay. Then treatment of choice. Treatment of choice for clinically significant macular edema and diabetic retinopathy is grid laser photocoagulation. It is not anti-VEGF agent. I'm telling again, if the question is treatment of choice for macular edema and diabetic retinopathy, is the question It is grid laser. Treatment of choice for proliferative diabetic retinopathy is pan-retinal photocoagulation. Treatment of choice for proliferative diabetic retinopathy is pan-retinal photocoagulation. Treatment of choice for macular edema is grid photocoagulation. ROP, please read. You have to know about the zones. What is zone 1, what is zone 2, what is zone 3. That is it to the question in ROP. Hypertensive retinopathy, usually they're not asking questions. Usually you do not have questions on hypertensive retinopathy. Here you have a question. Retinitis pigmentosa. Retinitis pigmentosa is a disease of rods or cones. It's a disease of rods. That's the question first. Okay. Then you have what is the classical triad of retinitis pigmentosa? Classical triad of retinitis pigmentosa, night blindness. Number 2, maxillary 3, attenuated arteriole, and 4, you have jet black spicules. So the most common symptom of retinitis pigmentosa is night blindness. The triad, that is the fundamental findings, will have a triad, characterized by waxy paleness opticus, arterial attenuation, and jet black spicules or bony spicules. Okay. Then I'm not going into the details of all this. Retinoblastoma. Retinoblastoma, the most common question that is asked is, which is the chromosome which is responsible? The 14 band of long arm of chromosome 13. That means 14q13. Second most common malignant intraocular tumor is retinoblastoma. Okay, I'm not going to the treatment details of retinoblastoma. Then you have Keith's nodules and Busaka nodules. We're going to uvea. Keith's nodules and Busaka nodules are characteristic of granulomatous uveitis. Mutton fat KP is seen in granulomatous uveitis. KP is deposited in the portion of a triangle on the posterior surface of the cornea. What is the name of the triangle? It's called All's triangle. What is All's line? Subconjunctival scarring seen in trachoma is All's line. All's triangle is seen in uveitis. Okay. On the drug of choice in the treatment of acute anterior uveitis is steroids. It is not cycloplegic agents. Cycloplegic agents are only for relief of pain. You have reduced the inflammation here. So the drug of, you will always have confusion. Someone has marked the cycloplegic as the answer. No. The drug of choice in treatment of anterior uveitis or in any uveitis is topical steroids. Topical steroids, that too. Then this is an important question. Most common cause of chronic iridocyclitis in children is juvenile idiopathic arthritis. Most common cause of chronic iridocyclitis in children is juvenile idiopathic arthritis. JIA or JRA, juvenile rheumatoid arthritis. Okay. I'll stop here. I hope I've covered most important topics: retina, lens, glaucoma, uvea, conjunctiva, and cornea. Rest are small topics which are lids and this thing, orbit. Lids and orbit and community ophthalmology, I'm leaving. So not much MCQs usually come in these topics except for community ophthalmology where you read about vision 2020. Okay. Just in community ophthalmology, second thing what you read is what is blindness, definition of blindness. So those two things you have to read. Please go through the whole PDF of mine. That will save your time and you can answer most of the MCQs which will be asked from ophthalmology. I hope it has been useful. If you have any doubts, please get back to me through the organization. Okay, I am always welcome and will be always welcome to answer your question. Okay, thank you.